Welcome, everyone. Today we will going to discuss about a very high yield topic for USMLE, that is acute respiratory distress syndrome. So we will go through the pathophysiology, clinical presentation, diagnosis, management, particularly the ventilation settings, that is a very high yield, and the prognosis of acute respiratory distress syndrome. So this is a typical picture of alveoli. So here is the gaseous exchange takes place. So this is a blood capillaries that surrounding the alveoli, right? So in that area, the exchange of O2 and carbon dioxide take place, right? So the risk factor, that is a very high yields. The two risk factor, we will divide the risk factor into two types: a direct lung injury and indirect lung injury. So direct lung injury may be the pneumonia, aspiration, inhalation, and indirect lung injury, that is sepsis, pancreatitis. So this lung injury will lead to the inflammatory cell activation and increased permeability. Okay, so whenever the lung injury, whether it is a direct lung injury or indirect lung injury, it will increase this capillary permeability. So here is the fluid. So this fluid will move into the alveoli, and the alveoli filled with fluids, right? So when the alveoli is filled by fluid, why the capillary permeability is increased? Because of the cytokines. Injury release cytokines. This cytokine, so increased permeability mean increased fluid move from the capillaries into the alveoli. So when the fluid is increased in the alveoli, it will impair the gaseous exchange. So it will lead to the ventilation perfusion mismatch. When ventilation lead to hypoxemia, hypoxemia, and this hypoxemia lead to the hypoxic vasoconstriction. This hypoxic vasoconstriction lead to pulmonary hypertension, increase RV afterload, increase RV afterload, and another high yield thing, that is a, so this is a filled with the fluid. So alveolar fluiding lead to another thing, that is a decrease lung compliance, decrease lung compliance. We will discuss these things in detail. So here the risk factor. So direct risk factors: pneumonia, inhalations, aspiration; indirect risk factors: sepsis, pancreatitis, trauma. So it will lead to the this lung injury. What does do lung injury do? Increase cytokines. Cytokines lead to revision. So increase permeability, increase fluid in the alveoli. So the these things lead to the decreased lung compliance, alveolar fluiding, increased work of breathing, and severe ventilation perfusion mismatch, and severe hypoxemia. And increased hypoxic pulmonary constriction lead to the increased RV afterload and acute pulmonary hypertension. So diagnosis. So diagnosis is simple: new bilateral cytic insult, edema that is not explained by the cardiac ischemia, is basically the so arterial oxygen pressure and fractional inspired of O2 is less than 300. So this is a typical diagnosis criteria for the acute respiratory distress syndrome. So acute respiratory distress management, that is a super high yield thing. So it's start from the mechanical ventilation. So what will do, the three things in the mechanical ventilation will discuss in detail. That first is the lung protection, barotrauma. So barotrauma. So limit alveolar distending volume. So tidal volume should be 6 ml per kg of the body weight of the patient. And the plateau pressure. The plateau pressure, what is a plateau pressure? That is very important. It is a alveolar pressure. It is basically the alveolar pressure at the end of inspiratory hold maneuver. So it is a alveolar pressure and it should be less than 30. If it is more than 30, if this this risk of barotrauma. So we avoid the barotrauma, right? So ventilation. So tolerate permissive hypercapnia, right? So why tolerate permissive hypocapnia? To avoid the over distension of the lung. So alveoli are things. If we do the high pressure things, they will be rupture and it will induce the barotrauma, lead to tension pneumothorax, right? So how can you avoid? By avoiding excessive tidal volume, and this is tidal volume, that is very important, 6 ml per kg. So oxygenation, set lowest feasible F fractional inspired O2, because there the higher oxygen concentration will lead to the oxygen induced complication. So goal of oxygen saturation should be 90 to 96% to avoid O2 toxicity. Sportive care. So treat the underlying etiology. If it is sepsis, it will be the pneumonia. So treat that thing that will lead to the ARDS, acute respiratory distress syndrome, right? So prevent iatrogenic harm, negative fluid balance. So why is if the patient is a fluid, I will give the diuretics, that kind of thing. So patient is always positive fluid balance. So negative fluid balance is very important. Timely extubation, so minimize sedation, corticosteroid in the selective patient. So prognosis is a mortality rate, 40% death in the hospital due to the multi-organ failure. Morbidity rate 50 physical debility, 25% with the chronic pulmonary dysfunction, restriction and decreased diffusion, lung capacity of the carbon monoxide. Acute respiratory distress syndrome, initial ventilator management, that is a super high yield. So oxygenation. So oxygenation is a determined by fractional inspired oxygenation and PEEP. PEEP is a positive and expiratory pressure. So oxygenation is determined by two things in ventilator, FiO2 and PEEP, while the carbon dioxide concentration pressure is determined by tidal volume and respiratory rate. So keep these things, that is a very high yield. Again, I'm worth repeating. So oxygenation is determined by in a ventilator by FiO2 and P, while the CO2 is determined by tidal volume and high yield thing. Oxygenation by FiO2 and PEEP, positive and expiratory pressure. So oxygenation, if the partial pressure of the oxygen is more than 90, decrease the FiO2, right? If it is less than 60, increase the PEEP. So ventilation, if the carbon dioxide pressure is increased and the pH is less than 7.25, so you have to increase the respiratory rate and tidal volume as a last resort to decrease the carbon dioxide concentration. If the carbon dioxide concentration is decreased and pH is increased, so how will you um, uh, counter this thing? By decreasing the tidal volume, decreasing the respiratory rate and sedation as a last resort. While if the carbon dioxide concentration is increased, so tidal volume is a last resort. If the carbon dioxide concentration is decreased, then the sedation is a last resort. So ensure lung protective ventilation, avoid alveolar overdistension. So how can you do this? By measure the P plateau pressure. So we already know that about the P plateau pressure is it is a alveolar pressure at the end of inspiratory hold maneuver, right? And it should be less than by decreasing the tidal volume and adjusting the PEEP. So if it is less than 30, it will be the good. And if it is the risk of barotrauma. If you found this video useful, please like and subscribe my content and share this video